My dear students, welcome you all for this rapid rewind top PYQs discussion session. Exams are fast approaching. I understand what's going on in your mind right now, but as much as possible, I'll try to help you out. As far as my experience concerned, I have seen many MDS entrance question papers. In general surgery, particularly, so many repeated questions will come. So many repeats will be there. Okay, like previous year questions are repeated this time. So many examples are there. So usually every student will be prepared with these PYQs. So if you miss out these, it will be big loss for you, and your ranks will fall drastically. So you have to be well prepared with these PYQs, and never you have to get it right at any cost. Okay, that's what matters a lot for your good scores and as well as ranking. Today this is like a quick revision class for you. My students, they are very good. They have understood the concept. They have their concepts are good, and they have revised well. So this is a quick, this is like a mock test for you. Okay, mock test. I'll be sharing the questions. You will be sharing the answers immediately in the chat section. Okay, the chat section in the YouTube. So we'll keep it as an interactive session. Okay, and if anywhere any explanations required, I'll explain it, and if you have any doubts, you can feel free to ask any doubts anytime. Okay, so let's start. Start with recent exams 2024 MDS entrance exam questions. Okay, very important question and a very important concept for your exam point of view is oral cancer. I have been telling this since my class days. So one question was, what is the TNM stage of oral cancer of 4 centimeter size? Okay, T is 4 centimeter with distant metastasis and ipsilateral lymph node of 6 centimeter size. Okay, so many a times they'll make it very easy for you. You need not have to remember everything. Okay, one clue will be there which will help you to delineate the decipher the answer. Okay, so here they have given T is 4, and ipsilateral lymph node of 6 centimeter is there, and there is a M1 distant metastasis already present. So its possibility is only one. M1 comes in only one stage. Any idea which is that? What is the answer? Can you post it in the chat section, please? Answer is very good. Desi Doctor, Dhanashree, all of you, not even single wrong answer. That's what makes me astonished about my students. They're always right about general surgery. So answer is this is 4C. 4C. Why 4C? M1 comes in only 4C. Okay. Any T and N and M1 is included only in 4C. So if this is one thing we should know in detail. Okay, T, what is T1, T2, T3, T4, but they'll not make it very complicated for you. Something very different or something which is peculiar feature is there in whichever staging, then they'll ask you. In the class also I highlighted this feature. So this M1 comes in your 4C, so that should be the answer. Hope it's clear. Okay. Next question is, 60-year-old patient presents with a diffuse asymptomatic swelling in the parotid region for 20 years. But since 1 week, now she complaining of slight pain and numbness in that region. What does this show? What does this imply to you? So it could be a benign tumor, or it's a malignant transformation of a benign tumor, sialolithiasis or sialadenitis. What is the answer? Yes. The answer is very good. All are right. Excellent. Okay, so answer is B. Okay, so since it's there since 20 years means it must have been and it was asymptomatic as well for last 20 years. That means it was a benign swelling, maybe benign pleomorphic adenoma, which even the benign, if it lasts for very long time, then because of chronic irritation there, it may be transform into malignancy. So what are the signs of malignant changes? Rapid increase in the size of the swelling. Okay, so when there is a rapid increase in the size of the swelling, it stretches the capsule, the parotid capsule is stretched, so they may have dull aching type of pain in that area. And underlying the parotid, what is there in between the superficial and deep lobe, there is a nerve, facial nerve, right? When it is compressed, when the swelling is increasing in size, it compresses the underlying nerve, so they may have paresthesia or numbness in the region. So benign tumor, it was there for 20 years asymptomatically. Suddenly, since 1 week, why they will have pain and numbness in a benign swelling? And salolithiasis and salidinate is not possible for 20 years like that. So its answer is very straightforward, it is B. Next question is which of this is the gold standard investigation for lymphangioma? Okay, or lymphedema also. If they give the same, lymphangioma, lymphedema, which of the following is a gold standard investigation? I had told you what is the investigation of choice, what do you mean by best investigation, what is the gold standard investigation, everything we have discussed in the class. So can you please tell me what is the gold standard investigation for lymphangioma? Yes, very good, very good. Answer is very good, excellent. Okay, lymphoscintigraphy or lymphangiocintigraphy using a radio labeled colloid. Okay, we inject into the web space and get the imaging done. Okay, that can show you all the dilated lymphatics, any collaterals are there, wherever there is a lymph nodes present, everything can be very well delineated, even better than MRI or CT scan. This can give you a better imaging of lymphatics. So lymphangiocintigraphy is the gold standard, but we don't usually commonly we do this, but after all, ruling out all other possibilities of lymphedema or lymphangioma, to confirm or to know where exactly is the block, or whether the collateral channels are there or not, to delineate all this minute information, we may get this lymphoscintigraphy. Hope it's clear. Very good, all are right. Okay, you're all right, very good. So this is how the lymphoscintigraphy is done for lymphedema or lymphangioma, same. Next is a patient underwent radical neck dissection surgery. Radical neck dissection, for oral cavity malignancies, thyroid and all, we do neck dissections, right? Following which he complains of shoulder drooping. Which nerve is damaged during the surgery? This is the basic applied anatomy question. Okay, applied anatomy. Most of the surgery will be related to applied anatomy only for you. But here it's a very simple question, straightforward. They have asked, while doing radical neck dissection, okay, which of the following nerve injured to make drooping of the shoulder like this. Shoulders have been like drooped down. Answer is excellent, all of you. Very good. So it is spinal accessory nerve. Okay, it's not cranial accessory, dorsal scapular, no. It's spinal accessory supplies your trapezius. Trapezius is required for your elevation, rotation or retraction of the shoulders, right? Trapezius is supplied by spinal accessory. So spinal accessory mainly lies in the posterior triangle here. Posterior triangle behind the sternocleidomastoid, posterior triangle is there, no? There, when you take out the posterior triangle lymph nodes and all, you may injure the spinal accessory nerve, resulting in drooping of the shoulder. Excellent. Yes, winging of scapula, Dr. Harmandeep. Winging of scapula happens due to the thoracodorsal nerve, or latissimus dorsi nerve, nerve of Bell's nerve, it's called. Bell's nerve injury result in winging of scapula. Okay, that is different. Winging of scapula is different from this shoulder drooping. Okay, yes, very good. Yes, any other doubts so far? All okay? Any other doubts? Okay, next question. A patient was operated for thyroid disorder. Okay, thyroidectomy was done. Parameters were normal on monitoring. On the same day, around evening, patient developed pain and swelling over the neck. On exploration, of the surgical site, bouts of clots were found. What would have been happened to this patient? Again, you know this very well. We have discussed this in the class. Okay. So, what is this common complication after thyroidectomy? They are asking. Is it primary hemorrhage? Is it reactionary hemorrhage? Secondary hemorrhage or malignancy? What is the answer? Excellent. Excellent. What is best thing about today's class is I can't even see a single wrong answer. Anybody. Almost all are answering there and all are getting it right. Not even single wrong answer. That's the best part of the session. Very good. Okay, it's not primary hemorrhage. Primary hemorrhage means during the surgery, if there is any bleeding, it's called primary hemorrhage intraoperatively. Within 24 hours, after the surgery, if there is a bleeding due to slippage of the ligature, or what happens sometimes during surgery, the blood pressure will be low, or there will be vasoconstriction will be there, okay, due to some drugs effect. So bleeding may not have been noticed, but when the BP normalizes in the post-operative period, or when there is some vasodilatation, that bleeding may occur. Second, okay, it's called reactionary hemorrhage. Reactionary hemorrhage. Okay. So one of the common complications they may present with, it may be dangerous, life threatening sometimes, because sudden there is a bleeding here in the neck and it may compress the underlying trachea and patient may have sudden onset breathlessness if you don't intervene immediately, and if you don't take out the clots, you may patient may die because of difficulty breathing. Okay. Okay, next 2023 questions. A female had elbow trauma, came with injury to brachial artery. She was planned for vascular anastomosis surgery. Ideal suture material for this case would be, we have already discussed about all the suture materials and all. Now please select any one best suture for vascular anastomosis. See, I may not have told you directly, but you know what is polyglactin, what is catgut, what is everything you know. So for a vascular anastomosis, I told this, although I have mentioned this in the class, but which may be very useful for vascular to arteries, small arteries like brachial artery, very small arteries, to join that, which suture may be helpful? Please tell. Again, all are right. All are right. Okay. Polyglactin is absorbable. If you use absorb like catgut also, or gets absorbed in a week. How can you be so sure that within 1 week, whatever the anastomosis you have done, it will heal? You can't be so sure, right? So you always use non-absorbable sutures for vascular anastomosis. There are two options are there among these which are non-absorbable: polypropylene and silk. Among these, which one you will prefer? Polypropylene or silk? Polypropylene, yes. Why? Because it's monofilament. It can glide it goes smoothly into the vessel. Vessel is a very fragile structure, no? Silk is a braided. It's a polyfilament, multifilament or braided. It may injure the artery, the wall of the artery while when you pierce it or when you pass through it. Okay. So you prefer monofilament, non-absorbable suture, very 5060 polypropylene maybe. So the answer is C. Excellent. Answer is C. Okay. So this is the classification. You already know what are absorbable sutures, what are non-absorbable, and in which condition which suture is used. You already know. Okay. Okay. Another question on trauma. I told you most of the questions will be based on trauma for you. Okay. So revised trauma score includes all of the following components except this we have discussed. So many various trauma scores we have discussed in that RTS. I told you which is the most important one, and here is the question you see in the PYQs. It includes three things which is not the component of it they are asking you. Okay, very good. The answer is the pulse rate. Pulse rate is not the part. Okay, tachycardia is not a this thing. Respiratory is a part. Okay, Glasgow coma scale is a part of revised trauma score, and SBP. Okay, these are the three things, and pulse rate is not a part of revised trauma score. Hope it's clear. It's a very straightforward factual question. There's nothing to think or calculate or anything. You know or don't know. That's it. See. So these kind of questions you must know. So next, usually I have seen on an average of 5 questions have been asked from general surgery in each paper, direct from general surgery, and there are some 2 3 questions overlapping with others. Okay, maybe with anesthesia or anatomy and all. So overall, there will be 8 to 10 questions which are directly or indirectly linked to general surgery. Okay, so 5 questions will be there, and that 1 or 2 questions will be on trauma, and rest 3 we don't know. Okay, so paraplegic patient was suffering from a hip trauma. Post surgery, he was bedridden for 3 months and developed severe ulcers in the back as shown in the figure. Diagnosis would be, what is the diagnosis here? What is the diagnosis in this case? It's a, very good. All of you are answering correctly. It's a, it's not arterial ulcer. It's a not a malignant ulcer. It's a not traumatic ulcer. It is a pressure ulcer. It's a bed sore. It's a bed sore or pressure ulcer which can happen in the sacrococcygeal region, ischial region, because of the constant pressure over that area. Okay, so neuropathy, it's a kind of neuropathic ulcer. Okay, trophic ulcer, trophic or neuropathic all means the same. Pressure ulcer or bed sore, all the same. Okay, okay, very important. See, if these kind of questions come, no, this is a like bonus for you all. Bonus. Punched out margin of an ulcer are seen in which lesion? Which type of ulcers have punched out margin? Punched out means very deep. It's not actually margin. Okay, punched out edges. It should be. Question is wrong. Punched out edge. Punched out edges are seen in which type of ulcers? Okay, I'll slightly twist the question. This is very easy question for you because you, you know about 3 things here. About TB, you know. In TB, you get typical undermined edges. In BCC, you know rolled up edges, rolled up and beaded. And SCC, you know, it's surely averted. So punched out is should be in syphilis only. Syphilis is neuropathic, okay, or trophic type of ulcer in syphilis. So you get in syphilis you get punched out edges. Okay, so by ruling out other options, see, you don't know exactly about syphilis maybe, but you know definitely for what type of edge you've seen in TB, BCC and SCC. So by ruling out other 3 options, you can conclude that it is syphilis. Punched out edge seen in. Okay, so next question would be, see, these are the types of edges. One question will be there because I have seen in last 10 years minimum 4-year question papers have got same question. Same question. One is two questions maybe. One is on syphilis, one other maybe SCS or some SCC or something. Okay, there are two same which type, this type of edge seen in which condition they have asked. So out of 10, 4 question paper have got this question, means understand the value of this. So what, they may not ask you the same question, they may ask the question from the same topic. That's why we should be prepared about the other types also. This time they have asked about the punch out edge, means next time they may ask about some other types of edges. What are those? Everted edge, you know. Rolled up edges, you know. Undermined TB, you know. Sloping edges, where all you get venous ulcer or in healing ulcers you get. So this is how you read. Okay, you when you read, when you get some question, read in and around that, because the same question may not be asked in the next question, next exams, but from the same topic another set of question may be asked. Okay, so next, okay, from the trauma shock, another question: which of the following is an example of obstructive shock? There is some obstruction to the blood flow. So example for obstructive type of shock, this you already know, you learned in surgery, medicine, everywhere. So please answer. Is it tension pneumothorax, pancreatitis, myocarditis or pancarditis? Where you get this obstructive type of shock? Excellent. All are right again. It's a tension pneumothorax. Tension pneumothorax, okay? And in pancreatitis, mind you get hypovolemic shock, and myocarditis and pancarditis you may get cardiogenic type of shocks. Okay, so any what is it, tamponade, See, obstructive tamponade, pneumothorax, pulmonary embolus. In the pulmonary artery, there is embolism. So, blood not able to pass through the pulmonary artery. So, or any congenital heart diseases, you may get obstructive. In hemorrhages or any fluid loss, like in burns and all, there may be hypovolemic shock, or any spinal cord injuries, neurogenic shock, or like in MI and all, they may have cardiogenic shock, or if there is a where the vascular resistance is lost, vasodilatation happens, like in sepsis, anaphylaxis, or in some drugs and all, they may have distributive type of shock. Okay, these are the different types of shocks and examples you must know. Okay, one more easy question, straightforward. Identify the structure. See, why you feel all this easy? Because you have prepared for a very tough level of questions. We have been giving very tough questions during your PCTs or regular exams. So after going through all those tough questions, all these real exam questions becoming very easy for you. These are not really easy. They are average or they are good questions. But you are finding it easy because your level is here. You are practiced or you are used to this level. Now the questions are all at this level. So below your level. So you are finding it very easy now. That's why you are getting all right. Okay, don't think the questions are not so good or they are very simple. Questions are good. They are average questions, medium level. So answer here is identify the structure seen in the picture after thyroidectomy for surgery of multinodular goiter. They are referring to this. Okay, this is a tracheal ring. Tracheal ring. Trachea is the answer. It's not vertebra, esophagus, or any hyoid. Okay. Next, a female patient was operated for acute appendicitis. She later complained of tingling sensation in groin area in front of the perineum. Which nerve is injured? I don't. This is a very incomplete question, and if you, to be frank, this is not a question for you at all because systemic surgery can't be asked in MDS. Anyway, but if you have a little bit of idea about the anatomy, you can answer this. Okay. Is it ilioinguinal nerve, popliteal nerve, iliohypogastric nerve, genitofemoral nerve? Can somebody answer this? And now I want to know how you answered also, not just correct answer. Yes, answer you are all right. It's ilioinguinal nerve. Okay, you are right. But can you say even the iliohypogastric also correct? Genitofemoral also can cause, if the injury also can cause tingling sensation in the groin or in the perineal region. All three answers are one. Not at all popliteal. Popliteal not possible because in the popliteal fossa there. 1, 3 and 4 are answers, but best one is ilioinguinal because that is commonly injured during appendicectomy. Okay, when you do a muscle cutting incision for appendicectomy or when you put a drain for appendicectomy, ilioinguinal comes in the there only. Okay, so that's the most commonly injured nerve. Okay, not the next common is iliohypogastric, and in the inguinal region, not in appendicectomy, this is not never injured. Genitofemoral, maybe during hernia surgery and all, it may be injured. So the answer is in the appendicectomy, which nerve can be injured and causing loss of sensation in the groin or perineum region is ilioinguinal nerve. Hope it's clear. Okay. Yes, Libra, I have explained it. If you want more in explanation, let me know. Or it's clear? Okay. Can you please answer this? Treatment of lymphedema is done by all except. Treatment for lymphedema, you can do all of the following except. Limb reduction surgery can we do? Yes, limb is so big in lymphedema. Can we reduce the limb size by cutting it down? Or micro lymphatic surgeries just by joining or this thing, can we do micro lymphatic surgeries? Limb elevation to make it manually, like to drain the lymph. Can we ask the patient to elevate the limb? Or lymphatic bypass vessel graft? Which is the answer? Tough one, but still By ruling out, you can, some common sense, you can answer this. Answer is 13 is I think I have discussed this question in your group. Okay, the answer given in your books is wrong. It's not limb reduction surgery. Limb reduction surgery is done. In fact, I have discussed this in thyroid. I remember thyroglossal cyst when I was uh, explaining cyst trunk surgery. If you remember, cyst trunk surgery is done for thyroglossal cyst. Where else you do cyst trunk surgery? I had asked. That is in lymphedema. Means reduction. The whatever the excessive tissue is deposited, that you remove out, so reduce the girth of the limb. Okay, so limb reduction surgery is done, micro lymphatic surgery is done, limb elevation is common. What's not done, unlike arteries, okay, arteries, if there is a block, for example coronary arteries block is there here, what we do, we take another vessel and bypass, put a bypass graft, if there is a block here, we put another artery or vein which bypasses that block. That can be done in arteries, but not in the lymphatics. So lymphatic bypass vessel graft never done. In fact, a lymphatic channel can be joined with some other vein or lymph node. Lymphovenous shunt, lymphnodal shunt we call. Okay, we do that, but we never do lymphatic bypass vessel graft. We can't, if see this is a lymphatic, if there is a block here, we never take another vessel and do a bypass like this. This is done for arteries or veins maybe, but not for lymphatics. Hope you understand what you mean by bypass vessel graft. Okay, little tough one. Without knowing or without having some idea, you can't answer this. Okay, next, what is champagne bottle legs are seen in? You want to see what are champagne bottle? Okay, this is champagne bottle. Understood? Champagne bottle appearance. This is seen in which condition? Which condition you get this champagne bottle appearance? Answer is C. Very good, very good. Can you please tell me another condition where you can get this? Classically, in which other condition you can get this? Come on, answer. Yes, very good. Aparajita is correct. Because of lipodermatosclerosis, you get this kind of appearance. Correct, you're right. Where else you get? In chronic DVT also. DVT also you can get this. Okay, chronic DVT. Yes, very good. Dhanashri, Shreya, very good, excellent. So in varicose veins, because of the lipodermatosclerosis, long-standing varicose veins or DVT, you get this champagne bottle appearance in the legs. Okay. Patient was admitted in hospital for 1 month and was bedridden. Suffering from fever and vomiting, suddenly he developed swelling on the left leg, which was increasing from past 2 days. It would be due to bedridden patient suddenly developed leg pain. Your diagnosis is done. What is that? We have discussed this. Is it arterial obstruction? Is it because of cellulitis, lymphatic obstruction, or venous obstruction? Very good, Nami. Excellent. Come on, answer. All of you answer, please. I want you all to actively answer each and every question. Very good. The answer is, it's a DVT. Any bedridden patient, the venous flow will be because of no muscle action to pump the venous blood. So, okay, right? It can't be lymphatic obstruction, will not cause sudden onset of edema like that. Even arterial obstruction also can't happen. cellulitis, yeah, there may be edema and all, but suddenly they can't develop the uh, like one what a limb swelling like that, or pain can't be there like that in cellulitis. So answer is it's venous obstruction or DVT. Next. Okay, this is interesting. See, like this, some anesthesia related questions also can be there in surgery. Taylor injured the tip of the index finger, and abscess with uh, which were formed abscess with purulent discharge. Okay, there was injury to the tip of the index finger. Later on, it formed abscess with there's a purulent discharge from this. How will you anesthetize? You have to do incision drainage for any abscess. What's the treatment? Any treatment for abscess is anywhere abscess. Treatment is incision and drainage. Correct. So the question is, how will you anesthetize the finger before doing incision and drainage of this abscess? LA is local anesthesia with adrenaline, local anesthesia without adrenaline, occlusive dressing of eutectic mixture of lignocaine and pilocaine, general anesthesia. What is the answer? Why? Okay, GA ruled out. GA not at all required. Okay, general anesthesia. Eutectic mixture means we pilocaine and lignocaine. So two local anesthesias mixed in a definite proportion to make it a long locally acting anesthesia. That's usually used as a surface anesthesia. Surface anesthesia, for example, for a venipuncture, you want to do venous cannulation for a kid, or skin grafting, where you want to do surface from the skin. When you want to involve, that time you give a surface anesthesia for lungs area using, it's called eutectic mixture of any two local anesthesia. Now the answer is between A or B. Now tell me, you are all telling it is B. That's correct. Many of your written given the answers are explanation also very good. It's in the tip. So tip is already purulent. So if you give adrenaline has got a property of vasoconstriction. So if the end artery, the artery in the tip, if it get vasoconstricted, there will be no blood supply to the tip. It's because it's an end artery. So the tip may go into necrosis and gangrene. So you avoid using adrenaline in end arteries. Okay, so that is a good understanding here. Okay, very good. Aparajita has answered very well. To prevent vasoconstriction, adrenal ischemia. Harmandeep, excellent answers. Okay, so the answer is LA. Your preparation levels are very good. You are very not just knowing the things, but you understood the concept also very well. Really appreciate that. Okay, good. A 4-year-old child report to the OPD with complaint of midline painless swelling, which moved on protrusion of the tongue. No need to look at the options also, because you know only one swelling in the entire world which moves with protrusion of the tongue. Which is that? Many swellings moves with the deglutition, but only one swelling which moves with protrusion of tongue. Yeah, correct. Good, very good. Okay, the answer here is, what is the answer? It's thyroglossal cyst. Thyroglossal duct is attached to the this foramen cecum of the tongue. That's why any arising from thyroglossal duct, the cyst arising from the thyroglossal duct will move with the protrusion of the tongue, not other swellings. Okay, branchial cyst, 6 pharyngeal arch, no. Only which is connected to the tongue is thyroglossal cyst. So that's why it will move with protrusion of the tongue. Hope it's clear. Okay, like this. See, this is the thyroglossal cyst that moves with protrusion of the tongue. This is a branchial cyst. You know where is the branchial cyst present, where is the branchial fistula present. Last class we have discussed, and it is always in the anterior border of the sternocleidomastoid, branchial cyst. Okay. Next. Okay. Superficial burns will show all except. If you answer this, Your burns concept is very clear. Your burns is very, I told you one question definitely from burns. See, in whatever the repeats were there, I have removed. Okay, some questions were repeated in multiple papers. I have not included all these multiple times repeated questions. I have included only once. So if you tell me the answer for this. See, Libra remembers whatever the jokes I have done in the class, she remembers. Okay, good. Okay, very good. Your concept is very clear, very clear. It is pink and moist. That's correct. Blisters are present, yes, in superficial second degree burns you get blisters, and it is painful. Okay, but it heals without scarring. Correct. Superficial burns heals without scarring. So that's the answer. C is the answer. Okay, so these are the different grades of burns. You should know what is first degree burn, what is second degree, third degree, fourth degree, you should know, and features of each one you should know. This will be a question, potential question. This time also I'm expecting one question from this topic, from burns. So they may give a case scenario, or about the skin grafting. Skin grafting can be related to this. There were so many questions related to skin grafting, where you put, see, when there is a small area of burns or any area is involved. For example, you have a BCC, basal cell carcinoma here. You take it out. For to reconstruct that, you use full thickness graft. Okay, where small areas are involved. Okay, you use full thickness graft. Whereas where there is a large area of skin has to be covered, you prefer split skin graft. Because for full thickness graft, you need a there is only selective places from where you can take out the full thickness graft. Wherever there is a redundant skin, like from the, see, is a redundant skin elbow, from the supraclavicular fossa, from the eyelids, from the posterior auricular region, from the groin. So there are only a little amount of skin is available there. So to cover only small patches, you can use full thickness grafts, where you need cosmetically better outcomes. But otherwise, whenever there is a large area has to be covered. So keep this concept in mind. This will come handy for answering so many questions. Okay. Okay. What is this? This patient has this swellings that is single, soft, mobile, slips on holding. It is mostly likely to be. What's the answer? Is it ectopic thyroid? Is it glomus tumor? Is it rhabdomyosarcoma or lipoma? Okay, first two I ruled out. It may be between 3 and 4. Among 3 and 4, which one? Which one you think? Rhabdomyosarcoma. Rhabdo means from the skeletal muscles. Myo. Sarcoma means the soft tissue tumor. So can it be rhabdomyosarcoma or lipoma? You know, the classical feature of, or cardinal feature of lipoma is slip sign. It slips on holding. So that has been given here, that has been mentioned here. So it can be nothing than lipoma. Rhabdomyosarcoma can present like this, but they will be very hard, not soft. They will be very hard, and it won't slip and all, because it's fixed to the underlying structures, so it won't slip when you hold it. Okay, so hope it's clear. The fluctuation, no, Shreya. Fluctuation is present only in cystic swellings. This is not cystic. Wherever there is a fluid is present, then fluctuation will be present. But here it's the fat is the underlying content. So this is called pseudo fluctuation. Although in the room temperature, even the fat acts as a liquid, so what it gives you is pseudo fluctuation. What is more classical sign is slip sign. When you try to see, I showed in my class also, I have a lipoma here in my hand. Okay, in my hand. So when I tries to hold it, it slips. See, when I touches here, it slips to the other place. When touch here, it slips to the opposite place. So I have a lipoma here. Can you see? So some bulge here. You see, this is a bulge. When I try to push, it moving to the other side. See, this is called slip sign. Slip. When I'm trying to hold, it slips. Hope it's clear. You will never forget now. You will forget now. You will never forget. Whenever any lipoma comes, you will remember me first. Okay? At least in that way. Next. A patient presents with a nodular swelling in the neck, as seen in the image, that is non-tender, soft, cystic, and moves with deglutition. He has a history of sudden weight loss and history of taking ATT. Means ATT means anti-tubercular drugs. Okay, anti-tubercular treatment ATT 2 years back. What is this mass? This also I have again explained in the groups several times. Okay, can anybody answer again here? Is it thyroid nodule, cold abscess, tubercular lymphadenitis, lymphoma? A. Very good. See, your examiner may try to distract you or try to confuse you by giving some history of TB and all those things. But you are not get deterred by those distractors. It's a very straightforward. Any non-tender cystic swelling in front of the neck is thyroid swelling. More than that, it moves with deglutition. It's again classical of thyroid swelling. Sudden weight loss and all, maybe because of hyperthyroidism. It's not due to malignancy. So lymphoma is ruled out. Cold abscess, okay, it's because of TB and it doesn't move with the deglutition. Lymphoma doesn't move with deglutition. Tubercular lymphadenitis doesn't move with deglutition. Is it clear now how to rule out? And tubercular lymphadenitis and cold abscess may be tender, they're not non-tender. Okay, how to rule out? Don't get suddenly confused or get distracted by something like what is it? TB, it's just ATT is there, so it must be tubercular lymphadenitis or cold abscess. No, look at all the entire question. All the features should that match for that particular swelling or the answer. Only then you can go with that. Okay, you are the master of this topic. Okay, nobody can beat you in this particular topic. You have learned so well. Okay, that's Parkland formula. Can you tell me? These answers are very confusing here. We have to read completely. The very good question, I would say. Even a well-read student also can go wrong in these kind of questions. So please be careful while answering these kind of easy-looking questions. You should be very careful. They may be sometimes very deceiving. What is Parkland formula? Please answer. I have see now how to apply the class. I have made you write that it is 4 into percentage of body surface area involved, okay, into kg. Okay, right? This is what I had made you write. 4 into. Now there are two options in which 4 is present in two options. There is option 2 and option D. One is 2 to 4 ml given, one was 3 to 4 ml given. So which one you will choose now? I have Kishan sir has told only 4 ml. But in here the 2 to 4 ml be here, 3 to 4 ml be here. So which can be more so you will get confused. But read the entire option. 2 to 4 ml okay, into weight okay, into percentage of body surface area correct for 24 hours. That's all okay. 3 to 4 ml into weight, all this okay. But next half, how to administer that? In the option B it's given in half in first 8 hours and half in another 16 hours. In the option D it's given half in first 16 hours, and now you also slightly confused, I know, but we understand, we have learned, and we know it perfectly that half of the given in initial first 8 hours they need the more fluid, right? So initially they require more. So in first 8 hours half of the fluid, and then slowly in another half is given in over next 16 hours. Hope it is clear. So when such confusing questions asked, please look the options very clearly and you can clarify any kind of these confusions for yourself. Hope it's clear. Okay. Okay. A patient presented with hemorrhage resulting in respiratory obstruction after a thyroid surgery. See, I had discussed a similar question that time. Again, this question was there in the this is 2019 question, but concept was slightly different. concept, the question was slightly different. I had discussed this. They may present with uh, respiratory distress on the evening of surgery. The kind of hemorrhage is classified as. What is the answer? That is, yes, 22. The answer is very good. It is reactionary hemorrhage. Okay. So one question can be framed in different ways. Very good, Saurav. Very good. Okay. Clear? Okay. We had a class on this also. I have explained you the correct place to all the instruments we have discussed. In that, the correct place to hold the needle with the needle holder is, if there's a needle like this, needle, okay, where you will hold the needle with the needle holder, where exactly, which position, okay, whether between the anterior half and in the middle of the needle you will hold, or anterior 1/3 and posterior 2/3 you hold, or 1/4, 3/4, or 2/3, 1/3. They're asking you. The answer here is 24 or 23. The answer is, last question answer I have told, no? This is reactionary hemorrhage I told. Before that I told. The answer here is B. Answer is B. Okay, here also I told answer. All the questions I have answered correctly. Here it should be, answer should be D. Excellent. 2/3, 1/3 junction. 2/3, the anterior 2/3 and posterior 1/3. The junction like this. See from the 2/3, this is anterior 2/3 and posterior 1/3. In that junction, anterior 2/3, posterior 1/3. That junction you hold with the needle holder. Okay, that's the correct way. 21st question I have not answered. 21st is, I told the answer. 21st is B. 21st is B. I have answered. 23. Okay. 24. Deep abrasions are healed by. Abrasions means, you know, the scratch marks, abrasion, scratches are healed by. Primary intention, you know what is primary intention, what is secondary intention, what is everything you know. So answer please. Tertiary also called delayed primary. Correct? So answer please. 24, the answer is B. B is the right answer. Second, it heals on its own. Any scratch, we never suture it, or we don't do skin grafting, anything. If in the superficial or deep, it has to heal on its own. Any scratches, any abrasions. Okay. So the answer here is, if it heals on its own by granulation, that is secondary intention. Okay. You keep it open for some time, then you later on you close it. Then it's called tertiary intention or delayed primary healing. Primary intention means when the patient any wound, you suture it and it heals by minimal scarring. Okay, then it's called primary healing by primary intention. Virtuous triad. Triad of death, we have already discussed this. Triad of death, virtuous triad. Okay, which of the component is not there? Hypercoagulability, it is there. Okay, and sir, for superficial abrasion, what will be the answer? No, it's a secondary this thing only. Okay. Yeah. So, okay. What is it? The question is asked. Epithelialization and the primary intention. Okay. For superficial abrasion, yes, epithelialization. For deep, only deep, it is abrasions. It will be even including the granulation tissue, everything coming. Only superficial means only epidermis is gone. So if the epidermis is coming means, then it's called epithelialization. Whereas even the dermis and the subcutaneous tissue also abrasion is extending. So then it has to cover with granulation tissue, then the skin, everything has to come. Then it's called secondary intention. Hope it's clear. So here, virtuous triad, endothelial injury, and stasis of blood is there. What is not there? What is not a part of virtuous triad is? It's not a part of virtuous is thrombosis or platelets thrombus is not a component of virtuous triad. Hope it's clear. Okay, this is a straightforward questions. All those things you can't calculate, guess, or there is no understanding of concept much here. Okay, you have to know what are these triangles, the borders or the components, everything you have to know. Okay, virtuous triad, very very simple and must know thing, must know question. Bed sore is an example of. My god, I feel like I should have been writing this exam. I feel so. This is a 18 or 7, 18, 2018 question, I think. Bed sore is an example of. Please tell me, or just now discussed. Trophic, venous, arterial, tropical ulcer. This also I told exam in the class. Don't get confused between A and D. Both type of ulcers are present. Trophic means nerve related, okay, or pressure related, whereas tropical means related to tropical area, tropical region, tropical climate. Okay, so answer here is A. Surgical site infection, I have discussed this topic. So post operative observation for surgical site infection in non-prosthetic, you have not put any implant there. It's called non-prosthetic surgery, like in orthopedics, implants and all will be put, no? Or in the hernia, sorry, in general surgery, some hernia and all. In hernia surgeries, you put some mesh and all. So without that, in non-prosthetic surgery, when will you call it is a post-operative surgical site infection? Within what days? Within how many days? If there is infection, you call it as a SSI. Is the question. Yes. Answer is 30 days. Excellent. Answer is 30 days. So, superficial infection, in case of superficial SSI, superficial surgical site infection, within 30 days. Okay. In the deep surgical site infection, if it is in the muscle, fascia, the infection is there, within 30 days of surgery or 1 year of implants. Okay, if the implant is put within 1 year, if it's get infected, we call it as deep SSI. For organ space, again the same, within 30 days of surgery or 1 year of implants. So surgical site infection can be either superficial or deep, or it can be even into the organ space inside the abdomen. In 30 days, you remember SSI is called when it is happens within 30 days of the surgery. How to prevent the surgical site infection is also a question for you. We have discussed in the PCT also. Again, I am telling you, pre-operatively you can give prophylactic antibiotics, pre-operative hair clipping, not shaving, pre-operative antibiotic shower, short stay in the hospital, good nutritional pre-operatively, adequate blood control, okay, all those things. Intraoperatively, all the aseptic precautions should be maintained, avoid spillage of the contents, good surgical techniques, avoid hematoma, and use monofilament nylon, oxygenation, glucose control has to be done. The post-operative period also, control of infection with antibiotics, and remove drains, any foreign bodies you have kept, any cannula, catheter has to be removed at the earliest. Very sterile dressings has to be done. Early enteral nutrition has to be started. The glucose level should be under strict control. All this way you can prevent surgical site infections. Okay. Next question is another factual question. Most of them are factual. Okay, and my students are prepared for concept based questions, not this factual. Any concept, from that concept any question comes, they can answer. Okay, so N-butyl cyanoacrylate, I have used this when I was talking about the instruments or sutures, different sutures. I have mentioned about this. There are recent advances. Other than suturing, you can do something. Cyanoacrylate glue is used for skin apposition, hemostasis, disinfection, or tissue regeneration. The answer is already there. So all of you answered it is skin apposition to skin. So any very small child comes with a incisional wound here and all, we can put this glue and oppose the margins. Okay, so cyanoacrylate glue is used for skin apposition. Okay, pilonidal sinus has. In the name itself it is there. Pilo means what? Pilonidal. Nidus means it's a resting there. Nidus. Sinus means it's a blind ending pouch. Blind ending pouch is called sinus. In the sinus, what is there? They're asking in the pilonidal sinus, what is the content? Is it hair, bone, necrotic tissue, or nail? You want to see how is the pilonidal sinus looks? Just one of my patients. Pilonidal sinus, anybody answering? Okay, answer is pilo means hair. Pilo is hair is present in the sinus. It's called pilonidal sinus. It mostly happens in the natal cleft, near the anal area, just above that, in the sacrococcygeal, that natal cleft, whatever is there. There, because of the chronic friction, some amount of hair would have been gone inside into the dermis. There, foreign body reaction happens. So there is a sinus formation. So multiple openings are there through which chronic discharge will be coming. So if you open it, you will find hair which are gone from epidermis into the dermis. This is called pilonidal sinus. Okay. Next question. Calcitonin secretion is increased in which thyroid malignancy? Calcitonin is produced from parafollicular cells of thyroid. So which malignancy arises from parafollicular C cells? Is it follicular carcinoma, medullary carcinoma, anaplastic, or papillary carcinoma? 30th, the answer is the one and only B. All other arise from the follicular cells, but the medullary from the parafollicular C cells. So parafollicular C cells secrete calcitonin. So if there is a more number of parafollicular C cells, more calcitonin secretion. So it's a tumor marker for medullary carcinoma. Okay. So you can also know about other thyroid tumor markers this time. It can be as thyroglobulin is a marker for which thyroid malignancy, like that. You see, I told you same type of questions are repeating. Rolled out or averted margins are seen in. This is in 2016 question. This is actually repeated 2-3 times in the consecutive years. 16, 17, 18, 2-3 years same question was repeated, but I have not included it that way. Rolled out or averted edges are seen in tuberculosis, syphilis, traumatic, or SCC. Right? All are right. Good. Very good. So this is all becoming very easy for you. Very easy. Okay, that's it. I think these are the pure surgery questions. Okay, pure surgery questions from 2015 say 24th. All the question papers I have collected and discussed. So many like repeats were there that I have not like included multiple each time, but all the other questions from pertaining to surgery we have discussed. Okay, and if you have any other doubts or any other questions you want to discuss, please let me know. Another 2-3 minutes we can discuss, or else you can post any questions, any doubt in the group anytime. We'll try to sort it out. Another 1 week. Okay, don't panic for anything, don't be tensy. By this session, with this session, you must be very feeling very confident now. All of you have answered all the questions rightly. Okay, I could not find even a single wrong answer from any of my students there. I could only find all the right answers from you all. So this must be giving you a high boost, or your morale must be very high at this juncture. And Yes, sir, for the factor 8 replacement, cryoprecipitate, yeah, the best. Yes, depending on the options. Yes, it's right. Anything else? Sir, IM site of injection in child. IM we give mainly the deltoid or best site. I'm not sure about that. Best site. IM site of injection in the anterolateral part of the thigh we give mainly anterolateral part of the thigh for all the vaccination and all in children. It's given in the anterolateral part of the CC. Harmandeep was answered. Vastus lateralis. That's the anterolateral part of the thigh. Okay. Any other doubts? Hope this was helpful. The session mainly not to you have not gained any knowledge, extra knowledge here, but definitely a lot of what is this confidence you have gained for sure, because you all could answer very well with your preparations, and many of you like all the concepts are so clear for you. With these concepts, you can any kind of question in and around these concepts you can answer comfortably. But surgery, please I request you, you all should get all the questions right this time. Okay, no excuses at any cost. Surgery, any questions, please, you all must, you can do it, you should do it, and you will do it. I'm very confident. Okay. Okay, then we'll not waste the time. Your time is very, very precious. Okay, I am also spending my time praying for you all. Okay, because at the end only that's what works. Okay, after all classes have been done, we have been doing everything. At the end, more than you, we'll be having the responsibility. Okay, to get you through. Because ultimately a teacher's success lies in students' performance. If the students achieves good, that's a reflection of maybe a teacher. Okay, so if you do well, that's a good credit for us also. And if you don't do well, it reflects badly on us also. It's not you alone. Okay, it's we are also equally responsible. So please don't let us down, or your teachers. So at least for our sake, your parents sake, please another 1 week study very hard. Okay, revise, keep revising. Okay, keep revising. Repeated revision is required to remember everything. So with that you will definitely succeed, and wishing all the success. What is that question? Child is also, what is the question? Child is also 30 to 2, but it depends on number of rescuers. What is this? CPR. CPR I have not taught you, I think. Who was taught? I don't know. Pediatrics you have subject, or in medicine it would have been discussed. Yeah, the compression versus breathing ratio is 30 to 2, both for adult and child. Okay, that's yeah. When there are only one resuscitator is there, when there are three resuscitators, 1 and 2 and 3 and breath. Every fourth you can give one breath. 4:1. Yes, correct. 4:1 when the two resuscitators are there. Ria, you understood? 1 and 2 and 3 and 4. This thing. Then it is 4:1. Now, medicine they would have discussed this all these things. Okay, thank you so much. Thank you so much. Sir, is triceps we give subcutaneous injection? Triceps subcutaneous can be given anywhere, but not triceps usually. We subcutaneous usually insulin and all we give in the abdomen, okay, or in maybe in the arm deltoid region only, not in triceps region. Having said that, it can be given anywhere, okay, anywhere subcutaneously. Thank you so much. Thank you so much once again for all your active participation. I really appreciate that. 1 week before the exam, nobody would dare to waste your time like this. But you you are prepared well. So just to revise, I think this session was very helpful. Keep up the spirit, okay, and be very cool and composed. Don't be tensed. You'll be the thoughts will get blocked. When you're cool and composed, when there is a presence of mind is there, then everything whatever you studied earlier during your first year BDS, second year BDS, everything will come into your mind, and you will definitely answer. The best thing about these exams is the answer is right in front of you. Unlike your university exams, you need not have to remember or recollect anything. Answer is right in front of you. You need to have just pick the right answer or select. For that, your presence of mind should be good, or your mood should be good. If you are really nervous, agitated, like anxious and all, you have a thought block. You may end up in commotion rather than convincing. So be very cool and composed. Keep writing every grand test every day, and the exam day will be just like yet another day for you. It will be not really tensed. You will not feel tensed during the exam day. Okay, thank you so much. Thank you once again.